All right, great. Well, welcome, Elaine. I'm going to give you a quick introduction and then we can get rolling. Online with us today is Dr. Elaine Scallon-Walter. She's a professor of epidemiology at the Colorado School of Public Health at the University of Colorado, where her research focuses on the burden of foodborne diseases and improving foodborne disease surveillance and outbreak response. Dr. Scallon-Walter is co-director of the Colorado Integrated Food Safety Center of Excellence, COE, and co-principal investigator for the Colorado Foodborne Disease Active Surveillance Network. She is also director of the Rocky Mountain Public Health Training Center, and she's going to be talking with us a bit today about a peek behind the curtain about how national foodborne disease estimates are developed. And so with that, please help me welcome Dr. Scallon-Walter.
Thank you. Let me just go ahead and share my screen. Okay. All right. So hi, everybody. Thanks for inviting me to give this presentation this morning. I'm so sorry I couldn't be there in Atlanta to give the presentation in person. But I've been asked to give an overview of how national foodborne disease estimates are developed. So I thought I would do that. So, you know, how do we come with the 1 in 6 or the 48 million illnesses or the 1.3 million illnesses due to Salmonella? So talk about that and how we come up with those estimates, both kind of in a...
Hey, Elaine.
Yes?
Sorry to interrupt you. Could you toggle your display? We're seeing the presenter slide view.
Oh, okay. Thank you for letting me know that. How's that?
Perfect. Thank you.
Okay. So today I'd love to give you some insight into how we developed the national foodborne disease estimates that give us our 48 million or 1 in 6 Americans get sick from a foodborne disease every day, or the 1.3 million cases of Salmonella. But I also thought it would be useful to talk about those foodborne illness estimates and how they relate to the data that we're seeing from FoodNet. And I know Dr. Tokes came and presented yesterday, and I think talked about looking at FoodNet data to track incidents over time, you know, including those incidents for our healthy 2030 people objectives, but also how our foodborne illness estimates relate to some other metrics that you might hear mentioned. For example, some summary measures of health, including disability adjusted life years. That has been a big focus of the WHO, and there's US specific estimates from the WHO that will be coming in the next year or so. And then to talk about them in terms of how they relate to cost of illness estimates, which try and put a dollar sign on some of the illnesses associated with foodborne disease. So I wanted to start by talking about surveillance data and FoodNet, because this I think is a really important distinction between our foodborne illness estimates and surveillance. And also FoodNet is such a critical part of tracking our healthy people 2030 objectives, but also a really important data source for our foodborne illness estimates. So as you all know, and as I'm sure Dr. Topes talked about yesterday, FoodNet is an active surveillance system and is a sentinel system based in 10 sites around the US, including here in Colorado. So FoodNet does surveillance in a very precise way and is doing that consistently year by year. So allowing us to track the incidence of several important bacterial and parasitic pathogens, including Campylobacter, Salmonella, S-Tech, and Listeria, that we're using to track towards our healthy people 2030 objectives. So FoodNet is really critical for looking at trends over time. But when you look at FoodNet data, you always have to remember that FoodNet is collecting information on diagnosed illnesses. So illnesses that are diagnosed in the lab, whether it be by culture or by culture independent diagnostic tests. And several steps are required for somebody to be diagnosed. You have to seek medical care. Your physician must ask that you submit a stool specimen for testing. The laboratory then needs to test for that pathogen. that the laboratory needs to identify the pathogen in the stool, which obviously none of our tests are completely sensitive, and then that needs to be reported to public health. So when we ask, why do we estimate the burden of foodborne illness? Really, it starts with surveillance and the recognition that surveillance only represents the tip of the iceberg, and that there are many illnesses that are not reported to surveillance. So some illnesses are not reported to surveillance because of these underreporting factors, because somebody was ill with Salmonella or STEC, but they did not seek care, or they sought care and were not asked to submit a stool specimen, or the lab didn't test for whatever pathogen was causing their illness. But there are also other pathogens which are important cause of foodborne disease that don't have any routine surveillance system available. I think the prime example is norovirus. Norovirus in healthy people 2030, we're tracking outbreaks, but there is no routine surveillance system for norovirus. So conducting burden of illness or estimating the number of foodborne illnesses gives us an opportunity to provide an assessment of those pathogens that have a surveillance system available, and also those pathogens that may not have routine surveillance available. I think the other thing to be aware of with our surveillance systems is that, although we call them like the Foodborne Diseases Active Surveillance Network, not all these pathogens are always transmitted by food. They can be transmitted by other routes, such as animal contact, waterborne, person-to-person contact. And our surveillance systems aren't assessing whether a case was transmitted by food or by another route. It's just looking at that pathogen, which is an important foodborne pathogen, but could be transmitted through other routes. So whenever we estimate the burden of foodborne illness, we're not only looking at all of the cases attributable to Salmonella, but trying to estimate what proportion of those are transmitted through food. So our foodborne illness estimates give us that focus on specifically on foodborne disease. And in the US, our estimates have focused on domestically acquired foodborne disease. So really allowing us and our regulatory partners to focus on the burden of disease we think is attributable to foods consumed within the US. And that's why we're doing this, is to estimate the burden of foodborne illness. So alongside FoodNet data and other sources of information, that these foodborne illness estimates can help regulatory agencies and others prioritize policies and programs, decide how they're going to allocate resources, target educational programs. And then we hope that these foodborne illness estimates will be used to assist with risk ranking, cost estimates, and other work that is being done to inform how we target foodborne illness efforts. So I'm going to talk very broadly first about how foodborne illness estimates are derived, and then really focus in on how we've done this in the US, with a specific focus on how we've done it for the 4 FoodNet pathogens that are part of the Healthy People 2030 objectives. So we published a scoping review in 2021 that looked not just at our work in the US, but globally at how countries had estimated the global burden of disease. And the first thing to note is that they do this using a variety of different data sources. But you could generally group these different data sources into 4 different approaches that are used to estimate illnesses. The first and most common approach is the surveillance scaled up approach. There is a direct approach, an approach that we call syndrome or population data scaled down, and then lastly, the inferred approach. And what I'd like to do first is just bring you through each of these different approaches, and then, as I said, kind of focus on what we did specifically in the US. So I think the surveillance scaled up approach is probably the most common approach used. And I think the approach that is preferred over some others if data are available from surveillance. So we talked a little bit about FoodNet and what it requires for an individual to become diagnosed and included in FoodNet surveillance. So with FoodNet or with another surveillance system, we know the number of illnesses here at the top of our surveillance pyramid, and we want to estimate the number that are domestically acquired and foodborne at the bottom of our surveillance pyramid. So that requires us to have an understanding of, well, how often do people seek care for Salmonella or STEC or whatever your focus pathogen is? How often do they submit a stool sample? How often does the lab test for that pathogen? And what is the sensitivity of those tests? And lastly, how often are they reported to public health surveillance? So in the surveillance scaled up approach, we will start with the number of illnesses, which we'll get from surveillance, and then adjust for underdiagnosis. That should read underreporting. So we'll adjust for underreporting. So for cases that have been diagnosed in a lab, but are not being reported to public health. And then we'll also adjust for underdiagnosis. And underdiagnosis includes the test sensitivity piece, whether it's for culture or for CIDTs, lab testing practices, so how frequently labs are testing for a specific pathogen, specimen submissions, so how often somebody submits a stool sample when they seek care, and medical care seeking. So under adjustment or under diagnosis and adjusting for underdiagnosis is a really key part of the surveillance scaled up approach. And really a variety of different data sources are used in order to adjust for underdiagnosis, including sometimes expert opinion when there is not other data available to support a more evidence-based or data-driven adjustment. For medical care seeking and stool sample submission, many studies use surveys of the population where they ask about diarrheal illness and related medical care visits. So surveying people, you can't know how many people with Salmonella seek care because by definition, not having sought care or submit a stool sample, they have not been diagnosed. But you can mimic the syndrome or the symptoms that somebody with diarrhea would have. So asking about acute diarrheal illness, asking someone with acute diarrheal illness if they sought care and if they submitted a stool sample. So that can give us the information we need about rates of care seeking and stool sample submission. For laboratory testing and test sensitivity, those data often come from surveys of laboratory or the literature looking at the sensitivity of testing in a real world setting. So for example, in an outbreak where you know people have been exposed to a particular pathogen and are ill and have consistent symptoms, what proportion of those who are tested test positive, for example. So the surveillance scaled up is definitely one of the most popular and the primary approach used by studies wanting to estimate the overall number of illnesses. Another approach that has been used in other countries is the direct approach. And this is where you measure all relevant illnesses in a defined population. I think the best example of this are prospective cohort studies. So we have not done this comprehensively in the US. If you're familiar at all, in the UK, they've had the IID study or infectious intestinal disease study. They're now just beginning their third cohort. So they'll recruit people in the community, ask them to inform them when they have symptoms of diarrhea or vomiting, and then they will sample those people in the community and test for a whole battery of different pathogens in order to determine the frequency of those illnesses in the community. So this is direct because they're going directly to people in the community. They're not waiting for people to seek care or to submit a stool sample or to become diagnosed in order to understand that they're ill, but rather looking directly at the number of people in the community. Other examples of the direct approach, including serologic surveys, which we have done in the US. Toxoplasmosis is a great example, where there are surveys in the community conducted by CDC looking at seroconversion for toxoplasmosis. So this gives us a direct measure of the number of people in the US who are infected with toxoplasmosis. There's also been other efforts that include cross-sectional surveys. So yeah, there was one study in Puerto Rico where they went door to door asking people about symptoms of Ciguatera fish poisoning. So these are all examples of the direct approach. So a third approach is the syndrome scaled down approach, or the population data scaled down approach. So the syndrome scaled down approach, instead of kind of the opposite to the surveillance data scaled up, instead of starting with surveillance data, you're looking at either a syndrome or a population. So with the syndrome approach, you're beginning with the number of illnesses caused by a specific syndrome, and then estimating, well, what fraction of that, what piece of the pie is caused by a specific agent. I think one of the best examples and the chief way in which this approach has been used is with norovirus. So as I mentioned, as we begin this discussion, norovirus has no routine surveillance data available. And when we did the 2011 estimates, there really was a paucity of data for norovirus. So in order to estimate norovirus, we first estimated the number of illnesses due to acute gastroenteritis, and then estimated what proportion of these were due to norovirus. I will say in the interim years, the norovirus group has done a lot of work in looking at other sources to estimate norovirus. Another example in this kind of syndrome population scale down approach is using population data. So starting with the number of people in a population, and then estimating the proportion who became ill. So a good example here is looking at the proportion of children less than 5 who experience an episode of rotavirus. So rotavirus is something that is thought to primarily impact young children. So if you make the assumption that a certain percentage of young children have norovirus before the age of 5, that can give you an estimate of the number of norovirus or rotavirus infections in a given year. So the final approach, the inferred approach, is really the approach that you use when you don't have data to inform one of the first 3 approaches. So this is the approach taken when data from another pathogen or another syndrome or treatment or from another location is used to inform the number of illnesses caused by that pathogen. So you're inferring the number of illnesses for a given pathogen from some other information. So from the scoping review, a few examples was one study that used a drug and how frequently a drug was prescribed to treat a tapeworm infection to estimate the number of illnesses due to that tapeworm infection. Another example is a study that used data on HUS, or hemolytic uremic syndrome, to estimate the number of STEC illnesses. So the inferred approach, again, something we're using when we have limited data. I think in our US estimates, we use this for one pathogen for E. coli, diarrhegenic, other illnesses where we really didn't have any other information other than to assume the rate of illness was similar to ETEC. So there are the 4 approaches: surveillance scaled up, direct, syndrome or population scaled down, and then finally the inferred approach. And again, I think with any of these estimates, one of the steps that we take in the burden of illness estimates that does not really exist when we're looking just at surveillance data is estimating the proportion of these illnesses that are foodborne. And this is done using a variety of different sources. I will say that estimating the proportion foodborne can be challenging, and there's definitely a paucity of data. Often we will look to outbreak data to estimate this. So of the number of outbreaks reported over a given period of time, what proportion of these or what proportion of the outbreak associated illnesses for a given pathogen are foodborne as opposed to transmitted by other routes. Epidemiologic studies like case control studies, trying to look at the attributable fraction, or sometimes expert elicitation, which can range from, really just subject matter expertise and having somebody give you their best estimate of what proportion is foodborne, to much more sophisticated assessments involving a panel of experts and modeling that can give you an estimate of the proportion that is foodborne. So I hope one of the things that was conveyed by going over those different approaches to burden assessment is to really highlight that burden assessment or estimating the number of illnesses really is not an exact science. There's not one way to do this. There's not a formula. There's not, kind of a stepwise process for estimating a particular pathogen and the number of illnesses caused by that pathogen. Burden assessments or efforts to estimate the burden of foodborne disease are really driven by the availability and the quality of data. And the availability of quality of data, it's specific to that particular country or region that you're estimating the number of illnesses and at that time. So we would expect the availability of and quality of data to change over time. So decisions you make at one point in time may not hold at another point in time. In any burden of illness assessments, really there's a lot of decisions to be made along the way, a lot of different choices, and the end result is a set of best estimates. But really, these are best estimates given the people that are working on those estimates, and somebody else who was working on the same set of estimates, could have made some different choices that could have resulted in slightly different estimates. So estimating the burden of foodborne disease is not an exact science. It is an art. It is something that requires contextual knowledge. So in order to estimate the burden of disease, you really need to understand foodborne disease in that country, in that setting. You need to have good clinical knowledge and expertise in the group who's doing this work, and really a broad epidemiological toolbox. So the ability to use different approaches and to be flexible with the approach used to estimate the number of illnesses. So these efforts are often conducted by one or a small group of people, but really rely on a network of experts. So in any burden of illness assessment, you need the people who are really familiar with that particular pathogen to provide input on some of the decisions that you're making along the way to estimate those illnesses. Of course, in estimating the number of illnesses, we're working hard to be precise, but you need to make decisions and cannot be kind of in a state where you're afraid to make decisions because there's a feeling of uncertainty about if it could be this or it could be this. We're trying to be, creative but plausible. Like, make good decisions, make transparent decisions, and make decisions that seem plausible for that given pathogen. So I think for all of these reasons, comparing between burden of illness estimates at different points of time is really something that we should not do, especially for the purpose of assessing trends. So the methods and approaches that we use to estimate the number of illnesses, they do change. We want to integrate the most current methods. We want to incorporate the new data sources that they become available. So our methods and approaches do and should change over time. And because of this, really, we can compare the new to old estimates for the purpose of comparing trends. It's like comparing apples and oranges. So really encourage anybody who is interested in looking at trends over time. This is why we should focus on surveillance, including the surveillance provided by the Foodborne Diseases Active Surveillance Network. That is a much more reliable source of looking at trends over time, whereas efforts to estimate the overall burden of disease, really, you should see that as a snapshot in time based on the methods and the best data sources that are available at that point in time. So I've given you kind of a broad overview of the different methods or approaches that can be used to estimate the burden of foodborne disease. So I just thought I'd focus for a moment on the approaches that we incorporated into the most recent CDC estimates that were published in 2011. And there were two different papers that were used to estimate the burden of foodborne illness. One focused on major pathogens, and there were 31 pathogens that were included: bacterial, parasitic, and viral agents. And then there was another paper that focused on unspecified agents. So this was a group of agents which was thought to include pathogens for which sufficient data was not available to estimate the burden of disease, pathogens that were thought to be foodborne, also including some non-infectious agents potentially like mushroom and marine biotoxins, metals, and other inorganic toxins. So these two papers together are give you the 48 million illnesses, or the 1 in 6 Americans who become ill. So while, this is kind of what captures the headlines, is the 1 in 6 or the 48 million, where I really prefer to focus is on the burden of some specific foodborne pathogens, rather than looking at the unspecified agents. And the one thing this assessment was allowed us to do, and the reason I have 2006 there, that was the year that the estimates were based, so they were published in 2011. This assessment identified 7 major pathogens causing domestically acquired foodborne illness, hospitalization, and death in the United States. And we came up with these major pathogens by looking at the pathogens that cause most illnesses, the pathogens that cause most hospitalizations, and the pathogens that caused most death. So if you look at the pathogens that cause most illnesses, norovirus was by far the biggest cause of domestically acquired foodborne illness, followed by Salmonella, C. perfringens, and Campylobacter. And together, these pathogens caused about 90% of domestically acquired foodborne illnesses. If you looked at hospitalizations, Salmonella, norovirus, Campylobacter, Toxoplasma, and E. coli 157 were the leading cause of hospitalizations, again causing about 90% of those hospitalizations. And for death, it was Salmonella, Toxoplasma, Listeria, norovirus, and Campylobacter. So this paper emphasized Salmonella, norovirus, Campy, toxoplasmosis, E. coli 157, Listeria, and C. perfringens, the 7 pathogens causing a large burden of domestically acquired foodborne illness in the US. For our work in the US, this table highlights some of the data sources and approaches that were used. So you can see here, most of the pathogens we estimated using that surveillance scaled up approach. So starting with surveillance and then adjusting for underreporting and for underdiagnosis. So we had a hierarchical approach to what data sources we had available to us in the US. Often there may be more than one data source available, so we have to choose which data source do we use. For example, Campylobacter is captured through the FoodNet system. It's also captured in national disease surveillance, but we selected that for any pathogen that had active surveillance data from FoodNet, that we would use that as the best source of data. So for pathogens with data available from FoodNet, that was our choice. If data were not available from active surveillance from FoodNet, then we turned to passive surveillance systems like NNDSS or COVID for Vibrio, cholera, and other Vibrio. And if data were not available from passive surveillance, then we looked to outbreak surveillance data. And this was the only surveillance data available for 5 pathogens. So for pathogens that did not have surveillance data available, we couldn't do the surveillance scaled up approach. We used the scaled down approach, either syndrome for norovirus, astrovirus, and sapovirus, or the population scale down for rotavirus, and the direct approach for toxoplasmosis. So I want to focus just a minute on the healthy people 2030 pathogens, so Campylobacter, Listeria, S-tech, and Salmonella infections. So for these infections, we relied very heavily on data available from FoodNet. So not just the FoodNet surveillance data, but also data from the FoodNet population survey and data from FoodNet laboratory surveys. So just briefly, how we approached estimating the burden for these pathogens is we started with a number of cases reported to FoodNet. Though FoodNet is not national, it's in a surveillance area that covers just 15% of the US population. So first step was to estimate the number of laboratory confirmed cases in the US based on those cases that reported surveillance in FoodNet. So we did that by taking cases in FoodNet and applying them by year and by site to the US population. Because FoodNet conducts active surveillance, we assumed there was no underreporting. If a case was diagnosed within the FoodNet surveillance area, we were confident that that case would be reported to surveillance. To adjust for test sensitivity, we relied on data from the literature for culture, because our estimates are based on 2006. We didn't have to worry or address the issue of different diagnostic tests. Culture independent diagnostic tests were not being widely used at that point in time, but certainly for the next round of estimates, that is something that we're going to have to think about. And then for laboratory testing for Campylobacter, S-tech, and Salmonella, that data was based on FoodNet surveys of laboratories. So they're surveying laboratories in each of the FoodNet sites, asking them how often they test for different pathogens. And then for Listeria, it was just based on subject matter experts, because there was no specific data available. When adjusting for medical care seeking and stool sample submission, we relied on data from the FoodNet population survey. So we looked at, in the FoodNet population survey, how many people with acute diarrheal illness sought care and how many submitted a stool sample. And because we know that not everybody will submit seek care and submit a stool sample at the same rate, we distinguish between severe and mild illnesses. using bloody diarrhea as an indicator of mild and severe illness. So we looked among people with acute diarrheal illness who had bloody diarrhea, how many sought care and submitted a stool sample. And then again, among people with acute diarrheal illness and non-bloody diarrhea, how many sought care and submitted a stool sample, and adjusted separately for those different categories. For listeria, we needed to make assumptions about how often people seek care and submit a specimen. We also relied a lot on FoodNet data when determining the proportion of domestically acquired illnesses. So we looked within FoodNet data to see, well, what was the proportion of people who acquired their illness while traveling outside the United States, and then the remaining proportion was considered domestically acquired. And then for the foodborne portion, we looked at a variety of different data sources, including outbreak data and case control studies. We did, along with illnesses, estimate the number of hospitalizations and deaths. Again, that information coming from FoodNet. So we looked at the proportion of laboratory confirmed cases who were hospitalized and died by year and FoodNet site, and applied that to the number of lab confirmed cases. So not to the total number of cases, just to those that were lab confirmed, and then adjusted for underdiagnosis by doubling the number of estimated illnesses. So that was our approach to estimating illnesses, hospitalizations, and deaths for those pathogens. The one thing that I did want to kind of highlight is one thing that is not included in these national estimates published either by me in 1999 or by myself in a group in 2011. They don't include estimates of complications and sequelae. So we have hospitalization and death as an indicator of severity. They do not include estimates of complications and sequelae, the burden of which we know is substantial. So examples include acute complications like HUS and sepsis, autoimmune and inflammatory responses like GBS or reactive arthritis, Guillain-Barré syndrome, reactive arthritis, chronic gastroenteric diseases like irritable bowel syndrome. And then, of course, for toxo and listeria, there are many acute complications. We do have some of this data available. FoodNet conducts surveillance and has for hemolytic uremic syndrome. We've also undertaken other efforts to understand the burden of Guillain-Barré syndrome, irritable bowel syndrome, sepsis, and other complications and sequelae in the US. But it's challenging sometimes, even if you have illnesses, hospitalizations, deaths, and you have information on sequelae, to get a sense of, you know, which disease is most important. And this is where I'm going to turn to how these foodborne illness estimates kind of feed into some of the other metrics that you may see for assessing the burden of disease. So, you know, when asking the question, which disease is more important? Is it norovirus, which has so many illnesses, and by virtue of having so many illnesses has a high number of hospitalizations and deaths also? Is it something like listeria, which is much more severe, though it's a much smaller number of cases, but has a lot of sequelae, both for those who are immunocompromised, who get this infection, whether they're older, or pregnant women who can result in fetal loss or long-term complications for the infant. So number of cases, number of deaths, which is most important, or how do we interpret those? And it's challenging, but something we can do, and something these other metrics do, is look a little bit more into the severity of the case in terms of duration or the impact on their quality of life, or look at death and look at, you know, when people died from these infections. So one of the things that our summary measures of health, like DALYs or cost estimates that are often published, can do is take the illnesses, hospitalizations, and deaths that we produce, but also add estimates of complications of sequelae. So to provide some kind of aggregate measure of the impact of a disease across these very different outcomes. So compare in one measure listeria and those severe complications and sequelae with something like norovirus, which causes a large number of illnesses. So very helpful in comparing the impact of foodborne diseases with diverse outcomes. So one approach, one summary measure of health that is often used by WHO is the disability adjusted life years. So this adds years of healthy life loss due to disability, with years of healthy life loss due to death. So here is an example of somebody who becomes ill at the age of 20, develops a sequelae that impacts their quality of life. We attribute a disability weight to that, which here is 0.25. So this is a measure of how much their quality of life was impacted from the age of 20 to 60. At 60, they die. This is premature death. So 30 years earlier than expected. So that would be 30 years of life loss. So together for this individual, this infection had cost 40 DALYs, or disability adjusted life years. So this is the approach that is used based on the illnesses and deaths that are produced in some of these burden estimates, along with sequelae. And then for each, you can estimate for the cases in the general population what the number of DALYs are. Again, this is a very popular approach used by WHO. In 2015, they published a series of estimates that looked at the burden of illness globally and presented regional estimates for the pathogens included in their assessment, which I think there were also 31. In the next year or so, WHO will be producing another round of estimates, but this time estimates will be available on a country by country basis. So they are taking our most current estimates in the US and then adding estimates for sequelae. So something to be aware of and to watch out for. We did this assessment using disability adjusted life years in the US for the 7 leading pathogens that I mentioned earlier. So the citation is there, you can have a look at it. But just very briefly, Salmonella ended up with almost 33,000 disability adjusted life years, which was, I think, similar to toxo when you add both congenital and acquired together, in comparison to something like norovirus, which ended up with a lower number of disability adjusted life years, almost 10,000. So just as I close, the last example is economic cost. So the Economic Research Service of USDA and others in a university setting have done a lot of work kind of monitorizing these illness estimates. So again, taking our burden of illness estimates and attaching a cost to those, but also adding in sequelae. I have been working with Dr. Sandra Hoffman at ERS to estimate a new set of estimates. The most recent was based on the top 15 pathogens from the publication in 2011. The new ERS estimates which have been accepted and are in press at foodborne pathogens and disease, are now expanded to include all of the 31 major pathogens and unspecified agents included in the 2011 publication, and include an expanded number of complications and chronic sequelae, including reactive arthritis and irritable bowel syndrome, and enhanced by with some disease modeling and new cost estimates. So in the ERS estimates, so they're attaching a cost to both illnesses, deaths, and to those seeking care, hospitalized, and those with sequelae. So there's a cost of medical treatment element for outpatients, hospitalizations, and chronic outcomes. They also include an estimate of lost wages for outcomes. So when you're ill in hospital, the time spent out of work and the impact of that time spent away from work, and there's also an estimate or a value attached to deaths. I could just give just one very brief summary from that publication, where looking at the 31 known pathogens and the unspecified agents ends up with an estimate of about 58 billion. And again, that is has been accepted for publication, so hopefully will be coming out soon. So in summary, foodborne illnesses aim to estimate the true number of foodborne illnesses in a population. If estimating the number of illnesses is certainly not a direct, an exact science. It's an art. It reflects what data is available at that period of time, and for that reason, really should not be relied on for assessing trends because of the change in approach and methods. But does provide a foundation for other metrics, providing aggregate measures of the impact of disease, including things like DALYs and cost estimates. So this is a picture that was on the front of the publication for the 2011 estimate. Shows the gathering of the Mana. So I hope this presentation has given you a little bit of an insight into the art of estimating the burden of illness, and a little bit of insight into the approaches used. And with that, I had hoped to leave a little bit of time for questions, and I think we might have that.
Great, thank you, Elaine. Excellent presentation. Are there any questions for Dr. Scallon-Walter on disease estimates? I have one for you, Elaine, and this is a naive question, most likely from a data analysis standpoint, an estimate standpoint. But you mentioned on one of the slides that that you, when estimating underdiagnosis, you doubled the estimate. Is that a standard kind of multiplication factor for that, or was there kind of expert knowledge around that for that doubling? Can you expand?
I mean, you never just want to pull something out of the air and double, but this was kind of a holdover from the 1999 estimates that Mead had led. And when we published the estimates in 2011, we really didn't have a better, more data-driven approach to adjusting for hospitalizations and deaths. This is a little unsatisfying. You know, it was based on subject matter input in terms of this seemed like a plausible adjustment to make based on, you know, from the people that were involved in coming up with these estimates. I'm happy to say in the interim, because we didn't like just, you know, pulling a number out of the air and not having some good data to support it, that we have done some work in the interim trying to provide a more data-driven way. So there is a new round of estimates underway, and they have a different approach to estimating the underdiagnosis multiplier for hospitalizations and deaths, which ends up with a number similar to 2, but you know, happily is a more data-driven than relying on subject matter expertise.
Great, thank you. And we have another question from Martin Reedman.
Hi, Elaine. So with regard to Healthy People 2030, so one of the ideas obviously is to sort of benchmark where we are now, where we are in 2030, and want to see improvements. And if we don't see improvements, we're not doing our job. The challenge is, yeah, the system for disease reporting, because it's based on reported illnesses, changes because, and you know, the big one is obviously changed from your classical methods to culture-independent diagnostics for some organisms. But you could see other changes, such as changes in healthcare coverage, et cetera, that might impact percent of people with certain symptoms that actually get tests or the appropriate tests, et cetera, et cetera. So if you look at 2020 reported disease data and 2030 reported disease data, you might see, reported disease rates per 100,000 is flat. But in reality, that might suggest an improvement in food safety or a reduction in food safety, depending on how these reported diseases are derived. Are there any efforts you're aware of to sort of estimate and account for the changes in surveillance, testing, doctor's visits, all of that in order to help us to better compare data over 10 years to get true estimates how we do in improving or changing food safety.
Yeah, thank you. Yeah, I mean, all of those changes that you mentioned are certainly important. I think the IDTs is really the elephant in the room for both looking at trends over time and for looking at burden estimates, because you know, we are detecting a lot more cases now, you know, and for the pathogens that we're focused on for healthy people 2010, like for 2030, particularly for Campylobacter, it has been a huge increase in the number of cases detected using CIDTs. So, you know, what you're talking about in 2030 is trends. So we want to be focused on FoodNet data for that. And, you know, I think the work that FoodNet has done a lot of work on trying to make some adjustments for CIDTs to look at trends over time in a more meaningful way. Of course, you know, they recently completed just another round of the FoodNet population survey, trying to understand any changes that we've seen in medical care seeking and stool sample submission. You know, I think it is a real challenge because what we've relied on for so many years was, you know, the understanding the surveillance pyramid, but also that the surveillance pyramid, you know, we weren't seeing kind of major changes in care seeking or how something was being tested for, the frequency of testing or the sensitivity of testing. And I don't think that's true anymore with CIDTs. There's been a huge shift, and I think it makes it very difficult to look at trends over time, and specifically for the burden estimates. You know, do you consider a case, the CID case, to be a case? Do you consider it to be less than a case? You know, so I think we are able to detect more cases now with culture independent testing. It's likely driven changes in testing from physicians and for maybe even for healthcare seeking. So I think we've seen a real shift, and I think it's a real challenge to try and incorporate that into a trend over time. But again, that's more FoodNet than looking at the burden of disease.
Great, thank you. Any other questions for Elaine? You have one more?
Hi, Elaine. David Goldman. Nice to see you. Thank you for being here. You touched on the changes in the proportion that are foodborne for any given pathogen. And salmonellosis is one in particular, I think, has a high burden, of course. We have a Healthy People work group focused on salmonella derived from poultry, chicken in particular. But if I understand, your estimates were 95% were foodborne, and I think the estimates these days are much lower than that. I don't know the exact number. Can you walk us through how that, you know, just drill down a little bit on how that came to be?
Yeah, so the salmonella proportion foodborne was based on outbreak data and case control study data. So if you looked at the outbreaks reported and the proportion that was foodborne, you know, that you're and in conjunction with the case control studies from FoodNet, you came up with 92%. You know, this is always the tension between trying to be data driven and plausibility. You know, I think we were thinking that was high at the time, and one thing that reinforced that thought was after we looked at the burden of these illnesses that were attributable to animal contact. So when you started putting the foodborne proportion of 92% and then etch out some room for animal contact and for waterborne disease, you know, it's clear that the 92% was, and we believe is high. So in the next round of estimates, which are currently being worked on, we're relying on, instead of outbreak data, an expert to rely on an expert elicitation that was done. So having a group of experts come together and look at the data that was available, but estimate the proportion that was due to food or waterborne or animal contact when considering all modes of transmission at the same time. And I think that's the key, is looking across all foodborne modes of transmission. Because if you're just thinking foodborne, or just looking at the data and looking what proportion is foodborne, you can tend to overestimate. Whereas if you have to parse the pie out with all the modes of transmission, I think it does a better job of giving you a better estimate of each of those modes of transmission. So there was work that CDC had published looking at an expert elicitation of the proportion foodborne for each of those. I can't remember exactly the proportion for salmonella, but it was between 60 and 70%, I think, depending on what serogroup you were looking at. And that's what will be used going forward. So the proportion foodborne salmonella will decrease in the next round of estimates.
Great. Thank you so much, Elaine, for your time today. We really appreciate it. And I believe that your slides and recordings will be available to you. We'll figure out where we're going to put that. But thank you for joining us so early Mountain Time and for the excellent information. So let's thank Dr. Scallon-Walter.
Thank you.
All right, Elaine, thank you so much. We'll talk soon.